of your outline. It talks about the hierarchy of a plan of care, and so this is what we will see as buttons when we click on the plan of care button. It's on the body buttons on the lower right of your screen, right above work list. And for me, I have some stuff on here, but I set it all to inactive. And so yours should be blank. Is that correct? Everyone has a blank? Maybe Kate has a few things.
Click on your plan of care button. You're on the work list right now. There you go.
Okay, you have nothing? Okay, good. Please disregard these on my screen. I'm gonna go through it and show you how to put things onto your screen also, but we'll just pretend that mine is blank. So when you are functioning in care plans, there's a hierarchy to the plans. You have an overview that might list a plan or a standard of care. And then we know that pieces of nursing care plans are the nursing diagnoses, the outcomes and goals, and the interventions. What Meditech calls nursing diagnoses is problems. And so when I click on problems, these might look familiar to some of you who are nurses, that these are definitely problems, but they're also a type of a nursing diagnosis. An outcome is a goal associated to a nursing diagnosis, and so this is the outcome that we want to see for the patient. And an intervention is something that we all use to work towards these patient goals together. Only RNs can set up plans of care for a patient. However, anyone can document on items of the plan of care if it's within your scope of practice, right? So you can document on vital signs because it's an intervention that's part of the plan of care. And we know that we want to monitor vital signs for every patient in our hospital, okay? That's kind of the basics of setting up a plan of care and the hierarchy of the order of things. On your overview screen, you have footer buttons of add, insert under, detail, document, change view, all the way down to utility. Everybody has those? Okay. Go ahead and click on the add button. What we have is a new patient admitted to the hospital, and there's nothing on the plan of care. So we can come here and we can add certain things. We can add a plan of care, and notice that the care plans are diagnosis based. So we know that this patient will be admitted for an appendectomy. And so we can view, the nurse that's gonna put this care plan on the patient can view what is part of this plan before they ever add it. Critical paths, we don't really use here. Problems are again those nursing diagnoses. Standards of care are like a set of interventions and tasks that every patient of this patient type in our hospital will have this care and treatment. Now, for med-surg adult, we did default IV therapy on there, but that does not mean that you can run at the patient with a needle without an order, okay? It's just the convenience of having that default on that you can chart on it. But everything else on here is pretty standard, right? We do this for every patient. So we have several standards of care listed. And there's even 2 pages. There's a next button in the footer. When you click it, you see page 2. Intervention sets are kind of like a standard of care, that it's a group of tasks or a group of interventions. But these are more specific. This specific patient is a fall risk. And so I can add fall prevention to this patient's itinerary, right? And these are the specific items that are listed for fall prevention. You can also add just single interventions, and we'll get into that too. The next row in the add screen is identifier, mnemonic, name, and any word. And you notice that whichever tab I click on, those always stay the same. Those are search features, and how you can find what you need without clicking through it, just page by page by page. Because tell you what, this intervention screen, I've clicked on it 10 times and I'm still on the A's. There's a lot of stuff in there, right? I'm gonna gonna have you click out of the ad screen by hitting cancel, and that brings you back to this overview, okay? So that's kind of the basics of what we have available to us in our care plan tab. On the first page of your binder, you have this help screen. And what this does is it explains some of the things that we see on the screen right now. We're gonna go through these routines in detail, but I wanted you to know that the first page of this section is the reference point for you. You can go ahead and turn the page. And you should have that free texting frequencies, okay? I'm gonna just have you guys look up here at my plans, and then we'll go through this again, and I'll have you guys adding to your own plans. But I'm gonna expand this inactive plan on my patient. And I wanted to point out that in the overview tab, we have columns. It shows the type of item that this is, and where we just talked about the hierarchy, we have plan, problem, outcome, and interventions that help you to meet that outcome, right? Then we have a description, and these little buttons here, they can expand and collapse what we have here. When you click on a minus or a plus sign anywhere, it'll expand certain things and contract them. This one on the very right in the header expands everything all at once, and I like that button a lot. These are just the description. This is the status. We'll talk about those things. Right here, you see all these little boxes in there? You can click on this box that has the I in it, and it brings you to some text related to that item, whether it was the plan, the problem, the outcome, or the intervention. There's some additional information on there. There's an A, that means that there's associated data. So on the respiratory assessment, when I click the A, if there was a respiratory rate documented, it's just there that I can review it. It's just a little piece of an FYI information for you. There's also P's, like on my Braden scale, I have a P. When I click on it, it brings up the protocol of how to do and score a Braden. And at the bottom of the protocol, all the way at the bottom, when you assess this as a nurse, it shows you what low risk, moderate, and high risk would be as a reference point for you. So there's additional information on protocol. Protocols might also contain bullets of, for this procedure, make sure you do this, or make sure you document this. It's kind of like a reminder to the nurse as a reference point. The next column is the start date and time. This signifies when these items were placed on the patient's list for care plan. The frequency column says how often this item is to be performed. The target column, notice how it's gray on a lot of stuff that you can't even click on it, but it's white in a few places. It's only available for outcomes because target dates are goal dates that we expect this patient to meet the outcome. So when the nurse sets up the care plan, they put a target date on it, that the patient can realistically meet this goal in about 1 week. And they can change that as the patient needs change. But to set a target date, you would click in the box and then you can select your date. Now notice how in the frequencies up here, some of these are gray and some of them are white and are available. The plan will never really have a frequency on it, right? The problem, the nursing diagnosis of the plan, you don't really have a frequency of how often this problem will happen to the patient. It's kind of all circumferencing for the whole hospital stay until it's resolved. However, the outcome, you can choose to document on this goal twice a day if you want to. But really, when you set a target date on an outcome, you should just at least evaluate any progress the patient's making, and on that target date, it requires an evaluation of the goal. You can either reset the date or go back. And there's some documentation we would do on that item. However, interventions, we know, use frequencies, like our vital signs intervention. Our vital signs intervention has many things listed for frequencies. Sometimes we do them daily, right, or once a shift. Sometimes we do them surgical vitals, Q15 times 4, Q30 times 4, Q1 times 4. When I clicked on the frequency column here for vital signs, it gives me all of these options that I can change it to. So right now I just received this patient from surgery. I can start my surgical vitals. I changed the frequency, that starts right now on this clock, 15 minutes from now, I have a schedule that's due, okay? This free texting frequencies handout explains a few things about what you can do when you're changing a frequency. And since this column takes up so much space, I'm gonna put it back on Q4 hours. And when I put it back on Q4 hours, it's Q4 hours from now, from right now. Now I can click on the frequency and I can type something in Q7 hours instead, and that would be Q7 hours from now. But we usually do our vital signs on a pretty routine schedule, right? So I can type in 8 o'clock, comma, no space. If you put a space in, it won't take it. 12 o'clock, comma, 1600, comma, 2000, hit enter, and it will generate a schedule based on those times. And now I just did this from my plan of care. Before I ever went into document on the patient, I set this up that this can happen. And the primary nurse would be responsible to check those frequencies. We're gonna set it up that it'll default on there so that you won't have to be in there. But for training having to adjust a lot of these things all the time that are pretty standardized. But for training purposes, it's nice to be able to demo that. So because I've changed this in my plan of care, I'm gonna click on the work list button right beneath it. Oh, that's because I set it to inactive. There you go. So now on my vital signs, see how it says they're due at 8, 12, 16, and 20? Guess where my clocks are? Right on the mark, right? Clocks are produced by a scheduled item that has a frequency associated to it. Now, on your free texting frequencies, it says you can type in free text Q5 minutes, Q whatever H for hours, D for days. You can type in days of the week that we're only gonna do residents or like self-pay patients. We only do their vitals on Sundays. So you could say Sunday, SUN, 10 a.m. or whatever time you usually do them, or 0800, first thing in the morning. And you can save it that way. And you can have any of these combinations there. But something that's not on this handout for you that I'd like to demonstrate is that if I am changing a frequency and I don't want it to generate a clock, I can put .prn and that will not generate a clock. Now, intuition says that anything that's PRN won't generate a clock, which isn't so, because in pharmacy, when something's PRN in the background, they have to set it up to once daily at least, so that it's available to us once a day. It's kind of a background setting. So if we choose PRN, it'll generate a clock. I don't even know what the time is associated to it, but 11 o'clock you'll have a scheduled PRN. Doesn't make much sense, right? Put a .PRN and it won't generate a clock on our work list. However, which is handy, it makes sense. So in Meditech, anytime you put a dot anything, it will not generate a clock. So I can put dot 11:30. Now my vital signs, I think I put it in at 11:30. Really what I did is I put it in at dot 11:30. It will never generate a clock for me to do on my work list. So you have to be careful how you type in those frequencies if you put a dot on there. There's an audit trail that you can see who changes the frequencies when. So because it's a patient safety thing, we just need to be very attuned to how we put in frequencies. I can change it on my work list also, and we'll get into that in our next session. But I can click on it and I can type in, oh, somebody kind of messed this up and we're only doing vitals 11:30 once a day. Now I have a clock. And in 24 hours I'll have another clock until somebody goes in and changes it again. Any questions about those frequencies?
Just like if,
Yeah.
say like they have vitals at midnight, but then they have an antibiotic at 1, most of the time I'll wait till 1 when I gotta wake them up, take their vitals. Can you just, under the midnight thing, put the vitals, or do you have to go in there and change it every time you do that? Like if I would change it to 1, it'd always be 1,
If you
or
change
just
it
for
to
me?
if you change the schedule, the frequency schedule to 1, it would be that way for everybody. But if you want to document on midnight vitals, and just pretend that this is my work list, and I have an 11:30 vital coming up now, what I can do is I can say, oh, well, it's 1, but it was due at 11:30. I just click on it, and I would hit document, and it brings in the current time in there. So it would say, I'm charting on the 11:30 vitals at 1 o'clock, which, you know, critically thinking, you're prioritizing sleep, and you could justify why you would do that. Now, on my work list, if I had something that was overdue, it would show me a red time and a red column here. So if I went in, let's see if I can make it appear in red on vitals. Actually, I'll go into Spike, that'll just be.
Spike's got a lot of red stuff.
Spike's got a lot of red stuff. See how these are all overdue because they're showing in red, I know that they're overdue. This one's overdue by 34 hours, so nobody cares about poor Spike's I&O lately. But I can click on this item that was due yesterday, well, it was due, yesterday, early in the wee hours of the morning. Hit document, and it says this time for yesterday that I'm documenting against that occurrence, but I can change it to reflect today's time. And I can also change it to reflect a time prior to that, I actually did this at, 2300 that day before. Here it is, 23. So it was a 1 o'clock I&O scheduled, which is ridiculous anyway, but just for documentation demonstration. On the 7th, but I actually did it at midnight, I needed to go in and change my date. And I can always reflect my current documentation no matter what time the clock was. I can chart on a clock from 2 days ago on the 6th today. However, I cannot chart on a future occurrence. So like I didn't change my time, but I changed my date. And it thinks I'm talking about 11:30 or 11:50 p.m. So I can't go later than the current time. So now it wants me to go back and correct my times. Oh, well, I meant that at 10:50 for today. So I'm charting on a clock from March 7th at 0100 on March 8th at 10:50. And when I put something in here, it would save it. And it would say that it was done, and it would say it was done at that later date. So I can document any time in the past, just not in the future. And I can change my clocks accordingly that way without affecting the frequency for everybody else down the road. You know? So it'll still come up that it's due.
So like if there's a reason you didn't do it, you just click on it and then you can document why you didn't do it.
Yeah, I'm gonna click on these things, and I'm gonna say these are not done by going to the footer button in the work list not done and selecting the reason.
There's a free text on there too?
There is.
Okay.
There is a patient to sleep option too already built,
Yeah.
Kathy,
Yep.
so you could use that, in that circumstance, you could use that one.
But if you charted your midnight vitals not done, the clock goes away and you don't have another clock until 4 a.m.
It's better to leave it overdue and wait till 1
Yep.
and just chart it. And you can make a comment and make sure it's.
Yep. So I have this I&O. I'm gonna document that I'm doing it an hour and a half later. And I might have a comment box in here. If I don't, I can add a note to it and I can say, patient resting, undisturbed, vitals entered, whatever you wanna say. Vitals entered when the snoring went to a lower decibel, something like that. That is getting into a little bit more on the work list, but it's a very good train of thought because you can see how the plan of care and the work list are very much associated to each other because every intervention that's on the plan of care updates to your work list. So this whole work list of information for Spike is quite extensive. So is his plan of care. It's enormous. In fact, it's gonna take so long to load. It takes it just a minute or two. Just a few seconds, it's faster. And see how long that is? About the same length as that work list, right? We've practiced on him a lot.
None of our live patients should have that long of a, or they better not.
Yeah, we wouldn't think so. But good questions. So I'm back in my plan of care, and we've talked about how we can do the frequencies. We've talked about the hierarchy orders of plans of care, and how it affects us in our daily work on the work list and generating clocks. When you turn the page in your binder, this is the add to care plan routine. So your care plans are all blank, and we're gonna start going in and adding some stuff to them, okay? Now, this person was just admitted, your care plan's blank. I can't even chart vital signs, I can't chart anything until I put something in this care plan, until I put something on my work list. Because your work list is blank right now, right? There's nothing there? You can't document height and weight, anything. Who can legally put a plan of care on a patient? The RN. So you might be stuck waiting for the RN for a little while because the RN legally doesn't have to get the plan of care on the chart for 4 hours after admission. Well, we don't want to wait that long to be able to document on stuff, right? But we also don't want to try and pressure the RN into getting it on there before 4 hours. So we've set up standards of care that anybody can add to a patient's care plan based on their status and type. So if you know that the reason that the patient is in the hospital, you can go to the plan of care button and click add. You can click on standards of care, and you can say, okay, this one's an adolescent. I mean, everybody can recognize which one would be appropriate. Oh, it's a scheduled patient, they're only here for IV fluids. It's a newborn, it's an infant or a toddler. If you have a question and you're not sure which one to add, then ask the primary nurse. But a CNA can add a standard of care because it's an HCMC standard, it's predictable. But you can't really add anything else, okay? But this is a nice way that you don't have to wait for somebody to add things. Just communicate with each other, right? So I want you to click on the little I beside adult med search standard of care, and you can see all the items that are listed in there. And then there's a footer button that says return to lookup. When you have it highlighted in green, you can click save. And when you are in your plan of care overview, now you should have this standard of care listed. Does everybody have that? Did it say that?
Go into add, go to add, and then go to standards of care.
Oh, here.
Select the adult med search. It's selected down there, so click save. Okay.
There, that's the issue there.
Alright, so now, after you get that standard of care on, click on your work list and take a look. Does anything show on there? Alright, now we're good to go, we can chart. And our height and weight is in the vital signs routine, like it is now. Height and weight's in, you go to vital signs to chart it, it's that way in Meditech, okay? Just so you knew.
So like if there is something on the plan of care, if it's a standard, you can't change it.
You can't change what's in the standard, but like the IV stuff, if it's not appropriate to your patient, you can change the status of it, and we're gonna go through that next. Yeah. So we have this standard of care on our work list, and Kathy, do you see on your work list that it shows everything that you just added in your standard of care? Okay.
Oh.
When you click on the work list button? Okay, go ahead and click back to plan of care, and you see how some of those clocks defaulted in? When you click on plan of care, you can inactivate items that are not appropriate to this patient. So, say we end up that this patient doesn't have an IV order, the status for IV therapy, the nurse, not the CNA, can click on this and determine that it's not needed and cancel it. If you inactivate it, it means it was once actively part of the patient's plan of care, and then you decided it was no longer needed, maybe we got an order change, and it was inactivated. So inactive kind of says that once we had an order and then it was DC'd. But canceled says we never really had an order, it just was defaulted on and we decided not to use it. Some of these items you'll even get a delete option, so you can delete it or cancel it if it wasn't appropriate to the patient's care. The fall measures. Okay, no risk of fall here, so I'm just going to cancel that. You could choose to put it on hold if you wanted to. So everybody, when you click on IV therapy, can you, even if you're not the nurse, can you change the status? Okay, you realize that that's not in your scope of care, and there's an audit trail that will show that if you do that, so we don't want you to do that. We'll try and get it fixed, but it's not even a temptation for you, it's still working on that. So please just know that's not in your scope of practice. So now that we've put the IV therapy to canceled status, go to your work list, and you'll see that IV therapy is not on there. Oh, but we have a site change and tubing change. So we should go back to our plan of care, and on site change and tubing change, we should set those to canceled also. And when we look at our work list, we don't have any IV stuff on there anymore. All right, everybody up to speed on that? Any questions? All right, go back into your plan of care.
But mine says it's inactive. IV therapy is inactive, but it wasn't active then.
That's been changed, go back to plan of care. And change that to
Oh.
cancel.
Now go to
Work list.
There we go.
So if you think that, you know that you're familiar with the standard of care, and you know that fall prevention is on there, and you've had this patient before, a frequent flyer, you know that we're gonna need fall prevention on them, and you go to document it and it's not on your work list, but you know it should because it's part of every standard of care, that means that the nurse has inactivated that. And if you have a concern about the patient, then that's a really good point for that professional communication to say, oh, you know, they were really wobbly on the way to the bathroom, and I went in to chart that I did fall prevention, it wasn't there. So can you add it for me so I can put that in there now? They need to reactivate it. So everyone's functioning together on the plan of care, it's a teamwork for the patient. So that's how you can add a standard of care. Everybody can do that. Go on down to the add footer button again. If my patient was here before, and this wasn't their first admission, when I clicked on previous accounts, and I'll show you on Spike maybe. No, actually he's still here as a first timer. I think Spike's been here. If this person had been here before, previous accounts would kind of show every plan of care that we used for the patient the last time. So it's just kind of an FYI to the nurse, as a reference point that this patient maybe had feelings of self-harm at their last visit, so something to kind of be aware of. And do we need to consider adding that to the plan of care this time too? So there's some options there. It's just kind of handy. But usually on a new patient that's never been here, it just shows you care plans. And you can see in your binder now, you have a colored screenshot of the care plan field, highlight in the add to plan routine. And so abruptio placenta is the first one that's listed for like an OB patient with a rupture or something like that. And when you click on the eye and you turn the page, this is the view you get when you click on the eye. And what's listed there is angina. So you click on this and you can see these are all of the items that will come onto my plan of care for angina. So I'd like you to select angina and hit save. And go ahead and add it to your plan. Everybody get it?
Now it added all the standard cares for CMO with angina.
It added every piece of the
So
plan.
that's how it's supposed to look then.
When the nurse puts on a plan of care. Yep, that's how it'll look.
Pages. Mine shows up to my ears. I have to hit detail to get to your screen. This is what it comes up to.
Oh, don't let it give you nightmares. Yeah, I fixed everybody's but yours apparently.
Just making sure, she was testing you.
We'll get into that. But for now, you have a footer button that says change view.
Yeah, I can get to where
To-
you're at.
to get
I
to
just
list.
wondered why I was turning it.
Yeah. Who was it? Phyllis said, oh, that's gonna give me nightmares. That change view. So everybody sees this same screen, right? Angina with the standard of care. Is everybody there? Yep. Okay, good. Way to go. So you have all of these items now that default onto your work list. If they have a frequency associated to it, that defaults to your work list also. Otherwise, if you look at your work list, there's a whole lot of things at the bottom that don't have any clocks. That's because there's no frequency on those items yet, right? So in the plan of care, you see the plan is angina. The problems 1, 2, 3, and 4 are the nursing diagnoses. The 1, 2, 3, and 4 determine the rank of the problem, which is the priority that the nurse puts on the problem for this patient. Those are adjustable, but they default in this way. And for the most part, we would agree that the altered cardiopulmonary tissue perfusion would trump any other problem. Because if that's the main problem and you don't have it, you're doing CPR, right? So that kind of does trump pain. Even though we know pain is always a priority, CPR comes first in that case. So altered cardiopulmonary tissue perfusion and pain are almost a tie, but in this case, number 1 and number 2. If you wanted to change the rank and you were the nurse that has the scope of practice to do so, you can go to the rank footer button. You can highlight this plan and you can say move it down. I really want my patient to be comfortable while I'm doing chest compressions. And you can apply and save it. And when you go back to the care plan, now altered cardiopulmonary tissue perfusion is ranked as number 2 and pain is number 1. It doesn't change the order that they appear in the list, but it'll show you the rank, okay? After the problem, we have the outcome, exhibit optimal tissue perfusion. For this outcome, we can set a target date or a frequency should we so decide. And listed underneath exhibit optimal tissue perfusion, we decided, well, we should probably do a cardiac assessment for that patient. That would be a good idea. So we can set a frequency for that also. Now, cardiac assessment is actually part of our big physical assessment, and so you wouldn't have to go in and document a separate cardiac assessment. We have some cleanup to do in the care plans, as you can see, and we just need to go in and adjust the interventions that are showing up in there. You saw that big, huge list of care plans that are in there. We have a lot of work ahead of us, so we're going to do our best to get this done before we go live, but I have a feeling that we're going to continue the work after live on that. And so some things that default on there you might not use, such as cardiac assessment, because you're already charting it somewhere else. There's no reason that you have to double document on those things, okay? And we have some flexibility in our state regs, how they want to know that the care plan is up to date and appropriate for the patient. Where we're implementing this software, we do have a little bit of leeway there. So it's not your fault that these things are coming in. You can choose to inactivate it on the care plan though, if you would like to do that. So cardiac assessment, I'm probably going to just inactivate it, and I have the option to delete it from here. But I'm gonna actually leave it there so that I can demonstrate a few things to you. But you're welcome to get rid of it if you'd like to. So multiple plans, I have multiple plans, you have one plan. One plan can have multiple problems associated to it, and I can see that everything between these thick blue lines belongs to the same plan. Does everybody see that thick blue line between their plan and their standard of care? Okay. On my plan, when I click in this little box, I can say a note about this entire plan. And when I type in here, I can type, my chest hurts. And I hit save. have an I in that box where I didn't before, okay? So this is something that says, hey nurse, there's something to look at in here. And this one happens to be not that significant. But I would want to put only things in there that I would want to catch somebody's attention that they should look at that. Now, the only place to view a note on a plan is in the plan of care, because as we have already seen, plans and problems don't show on the work list, right? Only outcomes and interventions show on the work list. On my problem, altered cardiopulmonary tissue perfusion, I have a note. Because problems are not seen on the work list, the only place I can view this information is in the plan of care. When I click on this for the problem, it's a nursing diagnosis of cardiopulmonary tissue perfusion, and this is going to look really familiar to those of you who are educated in care planning. Related to, look familiar, right? When you arrow down, and you don't get a scroll bar in here, so you just don't know that you're to the bottom until you use the arrow key on your keyboard. When you scroll down, then you get to see the as evidenced by. And these are just some suggestions to why you might be placing the care plan on this patient. And I'm gonna go all the way back up to the top, and I see that I have hypervolemia. Well, I think that, no way, this patient's here like for dehydration and chest pain, so I definitely do not have hypervolemia. And why would I have hyper and hypo at the same time, you know? So you can click edit, you can delete one, and this is how you customize the care plan specifically to that patient. When I hit save, every nurse that goes in to view the I from here will no longer see hypervolemia. All right? So you can do your related tos and as evidenced by in here. Some of them have some nice defaults that come in as suggestions, and you can go in and edit those. You can be the care plan queen of related to and as evidenced by. But I hope you nurse your patient just as much as you nurse your care plan, right? We don't want to spend so much time on care plans that we're ignoring our patients. They're our primary goal. However, the catch-22 there is we do want a care plan that does reflect our care that we're giving to the patient as the state requires us to do for legally providing care to patients. Now, we've talked about the plan and how you can put a text on there, or the problem with the related to and as evidenced by. The outcome is next in a plan of care, and it also has information on it. If I click on that information, this text defaults in. You can also edit this text to make it specific for the patient. And this is the criteria that we will evaluate the patient on to whether or not they meet this goal, right? This outcome. If I go in and I hit edit, I can say stable cardiac rhythm, optimal activity level. Now, patient's pretty lazy, not ever gonna meet that one. I can get rid of it for whatever reason. Again, I can arrow down and see if there's something else on there. When I save it, it's gonna save it, so every nurse that comes in to look at that will see that I have updated. There's an audit trail to who updates what, when, and you can even put in a why, because you can text in that box, whatever the heck you want, but it saves to the legal record, so don't say the patient's lazy. That would be not so good in a court of law. Now, exhibit optimal tissue perfusion, and I'm gonna set a target date of today. And I think that when I'm putting this date on here, I really think that we're gonna get this chest pain resolved. I have a feeling that maybe it's anxiety, and boy, that Xanax the doctor orders just gonna do the trick. So we're gonna reevaluate this goal today. When I go to my work list, I can see my interventions, I can see my outcomes, and I can see my meds. I don't have outcomes checked off, but when I do check off outcomes, I can see my outcomes in blue with a little target icon on there. And notice this, it's a green target, it's like a bullseye. And that tells me that it's due to evaluate today. I can evaluate it here by clicking on now or whatever time and hit document. And I can say, is it met, not met, or partially met? From here, I can still click on that I box, the information box, and I can see what I'm evaluating the patient on. And then I can say, oh, no way, not met. If I'm documenting not met for whatever reason, then I need to click on here and I can change this target date. But the only way I can change the target date is by clicking the target And I can say, okay, I'm gonna evaluate this tomorrow instead. And now I'd like to notice that my target date is no longer green, it's black. It's a future occurrence. If it was a past occurrence, my target would be red. If it's due today, it's green. If it's due in the future, it's black. Okay? From the plan of care, see where I changed it to tomorrow on my work list, on my plan of care? When I open up that problem, look at my target date. It updated it automatically for me. What happened? What's that look?
Me?
No.
I gotta look too.
You gotta look too.
Okay, so if you, this is the blue you're talking about.
Yep, that's your blue
So I went in and I said I did it.
Oh, and I didn't tell you to refresh your screen. And so you documented that you completed it.
Okay, but the blue's still
Target
there.
date. Yep. The blue is still there, and the blue here is always there because it says it's blue, and it'll bring your eye to the fact that it's an outcome. And so, I'm gonna show you this real quick. If you said that it was not met, you had the outcome of the
Wasn't my target date supposed to show me a target here if I set it for today?
On the work list?
You need to, yeah, make sure you're.
So you need a target date in there.
Oh, all of it? There's
You
the
can,
targets.
yeah. I mean, technically, if we have an outcome, we should be setting target dates for those outcomes. And see how when I click up here, I'm just.
It does, but you have to make, it won't automatically show it.
It's due to the
But I
date.
mean.
I mean, in your
shouldn't these boxes
preferences.
be-
This
Yeah,
will-
that's where I set that at, is preferences.
That is
We
not
can
met.
set that in the background to automatically show the outcomes.
Refreshing.
I don't think it's set that way right now.
Oh.
And if you change it, then we're gonna actually do this tomorrow.
They don't really use
And
it.
it's not green, and now it's black because it's a future.
Preset.
This was a goal that was supposed to be evaluated yesterday.
So
You
they
click
were-
on this bullseye.
Yeah.
So how much of this do we have to do every time we work?
Well, how much do you want to do?
Where's your cameraman?
It's really
Not very
professional,
much.
it's a professional decision. We need to be responsible that we have a care plan that reflects the patient care on there and that we customize it to the patient. You can spend a lot of time adjusting all these little features, right?
I'm pretty sure
But I
Kathy
mean,
Horner
now
gives some
you get the
guidelines.
little thing that says you're supposed to review it.
Yeah.
So,
We're gonna go through that.
oh, okay, I mean.
You're just
yeah.
always one step ahead of me. I love it though. It's logical. It is.
Yeah.
When you have something important, like you're doing bladder retraining or something like that, bowel and bladder retraining, you can set a goal date and then maybe it becomes a little more important that we have a checkpoint. Or like our care plan meetings that we have, maybe we're evaluating a goal on that day and they say, oh, we need to try and really get this patient, you know, bearing more weight, 20% more weight by next week. Then we can adjust our care plans accordingly to show those major target dates. But to set something for every single one, you know, ideally we have outcome dates on our plan of care, but we also have to provide patient care at the same time. And you can see it could take you a long time to update some of these lengthy plans of care. You have to make that professional decision. So, after a problem, you have the outcome. After the outcome, you have the interventions that help you meet that outcome. Some interventions have some text on them. Some interventions might even have a protocol associated to it, like the Braden, if we had a plan of care for a wound that was impaired skin integrity, and we had an outcome of granulation tissue present within 5 to 10 days, then we would have a Braden scale also for someone like that. And the Braden scale might have information here that you can click on it on the intervention, and there would be a P in this box, or maybe an I, like this chest pain assess, let's see. This intervention for teach treatment plan, when you click on that, this is what we would be teaching for something like that. So there's like a little bit of extra information. It's a nursing communication tool also. When you can say, okay, this cardiac assessment, I've charted my physical assessment, I keep doing it, but I also want you guys to know that when you go and assess this patient, I want you to know that I found out that there was a congenital anomaly that the patient's cardiac tones are actually heard on the right side of the chest. I had a patient like that once, right side of the chest. Tones right side. Save it, don't mind my typos. It'll save to the permanent record with a typo, by the way, there's no spell check. And now, where that was blank, every time I go into cardiac assessment, there's a little information, hey nurse, this saves a legal record, by the way, but you should know that the patient's cardiac tones have been evaluated and the doctor's aware that they're on the right side. And I could even type in here physician aware, or physician notified in a date and time, so that everybody realizes that. And then the physician doesn't get 20 calls, oh my gosh, we have a transposition, you know, we're freaking out. Come look at this, I just don't know what I'm hearing, doc, come down here. Oh, I've heard it 3 times already, you know. It's an established history. Now look at my work list. I updated that here, and when I go to cardiac assessment here, I have the same I with the same text. So you can do it on the fly from the work list, or you can do it from the beginning when you put the plan of care on the patient. Any questions about plans, problems, outcomes, and interventions that default in from my plan of care angina? Okay.
So the notes that you put in there, like you just put that one,
Yeah.
say the next day there's something else and the nurse adds to that. So after the patient has been here for 3 weeks,
Yep.
is it just everybody's added note to it if you don't get rid of that, or is it new every?
It's not new every time. It saves throughout the
Right.
stay.
Okay.
Yep.
So at the end you could be reading something over and over again.
Yep. Exactly. Yep. Or you might see some new information in there.
Right.
Mhm.
So it could get long.
It could get long. Yep. And after a while, these protocols and stuff, you won't like go in and click on protocol all the time because you're going to know what the protocol is. It's a standard protocol. Click on it for easy reference, but it's right there. Now, I wanted to show you on the work list, if I was to document on this intervention, I also have the I here, so while I'm documenting, I have that I'm like, I wonder if anybody else noticed that. And I could click on it and, oh, okay, I see that. Now, this by no means is where you document physical information on your assessment. This is a nursing communication tool, but this is not a way to communicate to the medical record that patient has S1, S2 distinct or edema, because there's places for that within the assessment. Heart rate, heart sounds, edema. We need to be using those fields. But this would be an extra nursing communication tool that we can use here, okay? Just to make that clear. We'll get into documentation and the work list in the next session, but this is just kind of an intro to that. So, on my plan of care, we've talked about how to set target dates, and we can only document out of a plan, problem, outcome, and intervention. Only 2 things can we document on against those things, and those happen to be the 2 things that will show up on your work list. Can you tell me which one of the 4 of those are? That shows up on the work list from your plan of care?
Oh, what we can't document on problem or plan, so
Mhm.
intervention or outcome.
Interventions and outcomes, exactly. So we saw how to document on those things from the work list, where I put a check in the box and I hit document and it kind of came up. I can also document on them from the plan of care, and you'll notice in the footer button, there's a button that says detail and a button that says document. I'm on the cardiac assessment. If I hit detail, looks familiar, right? Same thing when you click the little I. When I go back and I have it highlight and I click document, looks familiar, right? Exact same thing I saw from my work list when I was documenting. If I'm documenting an outcome from here, and I hit document, same thing. It updates to the work list updates to the plan of care. your binders, we started with this add footer button, and we started all of this with one plan of care, right? First we went into standards of care, and then we went through and added a plan of care. So in your binder, I would like to point out that this first page that was plan of care, and you turn the page and it showed the details of what is included in the angina plan of care. And you can see that before you choose it for a patient by clicking on the blue eye. Okay? Information. Turn the page. This is a list of the problems. I'm going to bring that up on my screen right now. When I click on add in the footer button while I'm in plan of care, and I click on problems, and is everybody with me on here? Does everybody know how I got to this screen? Bruce's wife? Who needs chocolate?
Need steak now.
Needs steak now. Okay,
Problems.
so here we are at problems. When you click on the blue eye, it brings up the information related to just that problem. So I can add just a single nursing diagnosis without adding the entire care plan for angina. Okay? I can also go through and pick multiples. So I can pick activity intolerance and altered growth and development and add two at a time. I can do that in plan of care also. I can add angina and pneumonia or something like that. So you don't have to do it one at a time. But honestly, the cleanup's a little easier if you do it one at a time, because you can go active, inactive a little faster for one at a time and just know that you finished that one and move on to the next one. I can also go to a standard of care and notice how the problems that I selected are still here. It's because I haven't saved them over yet. So I have an appendectomy care plan. I have 2 extra problems. I might pick the standard of care of med-surg, which I've already done and saved. I can click the intervention set of fall prevention. And again, all these blue eyes will show the expanded version. And I can add all of those things to my plan of care all in one shot. But that's going to be a really big plan of care to go through and edit. If I added these things, I have added care plan items which have resulted in duplicate interventions. Would you like to resolve these now? If you select no, you can always resolve later in the utility, which utility is a footer button in this care plan screen. I'm going to go ahead and hit resolve now so I can show you what this looks like. So it shows me exactly which interventions I ended up with duplicates. And this says that it came from a standard of care. This says that it came from different care plans, and this is actually what the mnemonic of the care plan is. So it doesn't tell me much about the name of that care plan, does it? Just the mnemonic. So I usually go to keep the active things as the standard of care, and I'm just going to cancel the brain that came in as part of maybe a different problem that I added or something like that. And from here, when I go back, it updates to my plan of care. So then that other brain isn't even showing up on here. But now, boy, do I have a lot of stuff on my plan of care. Now, I only fixed one of my duplicates, but you noticed I had 4 on my list? What about those other 3? I didn't even bother to resolve those. Well, I got in a hurry and the patient was falling or something happened or I answered a call light, and I'm going to just come back to it later. It's in the utility button. So I can go to utility. When I have interventions, it shows me I have duplicates that are unresolved, and I can do them from here. And that's what it meant by, would you like to resolve these later? I can go to the utility and fix it up. We're going to go through all these features in the utility here in just a minute. In your binders, go ahead and turn from that problems screenshot. And on the next page, it shows what it is when you click on the I for activity intolerance. It looks at all the things that are listed for that problem. When you go to this next page, it shows standards of care. It lists some of the standards of care that we have. When you turn the page, if you click on the blue eye for the standard of care adult med surge, this is some of the stuff that we have active in that intervention set, in that for standards of care. When you turn the page again, you see intervention sets. And if you turn the page one more, for the intervention set of fall prevention, if you click on the blue eye, it lists all the interventions that are part of that set, okay? The last screen here would be interventions. And we showed that there's like multiple interventions. There's 10 pages of just A's, right? So how in the heck do you find what you're looking for when you just want to add one intervention? When you turn the page, you have a screenshot that I've already highlighted the word any word on there. And then I went through and I highlighted the word OB that I was searching for. You must always change your search field for the interventions to any word. In fact, it's a good practice for anything that you're ever searching for. Because if I search for OB, it only looks to the first 2 letters of the start of the name, the first word in the name, title, OB. And I might have a couple different pages of it. Obtain UA, really has nothing to do with like the OB that I'm looking for. If I click that to any word, see how I have comfort measures initiated, OB, shows up? That would have never came up unless I switched to any word. And maybe that was the one I was trying to find and I was frustrated because I couldn't find it. So every once in a while you might have something that you need to add on the fly. Like if I want to add a Glasgow because they fell and bumped their head or something. Or like an adult neuro check is something in here. And if I spell it right, jeez, and I'm on neuro, even if it's just part of the word, neurological, it'll still come up in my search, okay? So that's how you can kind of find those things on the fly. When I add the neuro cranial check, let's add the adult one to this patient. It's a miscellaneous intervention because I didn't add it in association to a planned problem or outcome. So it's going to appear clear at the bottom of my screen as a miscellaneous. Does everybody see that? If I should choose that I wanted to have that as part of my activity intolerance problem that I added, I can go into utility and I can fix it here by moving the miscellaneous. And I can say, this I want to move to, and it will give me all the problems that I have active on my patient. So I can kind of clean up and make my care plan prettier. And I can spend all the time in the world nursing my care plan, but I hope I spend just as much time nursing my patient. And report pain at a tolerable level. Apply and save. When I go back to my care plan, I no longer have that hanging out as a miscellaneous at the bottom, underneath that big blue line. It's now under report pain at a tolerable level, and it's an intervention on that care plan. Neurocranial check, okay? There's ways to organize that. And on my work list, I now have, on my N, neurological cranial check on my work list. Okay? So this is how we started with a blank work list, and we are slowly adding things to our work list appropriate to the patient's care so that we can go in and document appropriately. Go ahead and turn the page off of that OB any word search. This is that detail screen that shows that you can free text something on there. And if you turn the page, I have clicked the blue edit button and it says you can free text information here pertinent to the patient's care. This is available for outcomes and interventions. And they just updated this 2 weeks ago that you can put text on that plan like I showed you first. So you might want to add in that note and plans. And problems now also. So we've expanded. Meditech's always evolving. I'd like to show you something else. We clicked on this I and it took us to the item detail screen. And if I just highlight and I click the detail footer button, it takes me to the same screen, detail. When I have that highlight on detail and I click on history, this is the audit trail of anyone that's made any changes to this care plan item, just to show you that it is recorded. And that's what this next screenshot is. It shows you that everything can be recorded in there, okay? And it's the item history. A footer button that we haven't talked about on your list for care plans. So is everybody on the plan of care, and you have the overview, and you can click and you can see just the problems. You can click and you can see just the outcomes. You can click and see just the interventions. I like overview. The footer button we talked about, add. The insert under, if I click that, and I'm on impaired gas exchange for me, I can now pick an outcome to add to that problem. Accept self-worth, because you're worth it, right? And now I have accept self-worth as an outcome underneath this problem. This problem now has 2 outcomes. So it's a quick way that, oh, I want to add something right underneath here. You don't have to add it as a miscellaneous and then try and clean it up in the utility. You can just click insert under and put it there. Or you can go to add an entire plan. If you add a single intervention, it gets added in miscellaneous and you have to clean it up later.
How do you get rid of that?
Which one?
Say you put it somewhere you don't want it. You're like, oh.
It's a miscellaneous. It'll be in the utility, and we're gonna go through that in just a minute. Yep. The change view screen, you have a screenshot of that in your binder. Audrey has a problem with this on her screen because it defaulted her into spreadsheet mode. And I just want to demo for you what that looks like, but don't change your setting, it should be on list. This is what it looks like in spreadsheet mode, like nursing school spreadsheets that you had to fill out by hand. Problem, outcome, interventions, and your goals and everything. Some people get nightmares from that, so we've defaulted it to come into list, except we're picking on Audrey today. But she figured it out. So on that change view circle list, it really needs to be on list. It's so much more helpful. And this is another one where I wish there was a little icon that could whoop, slap your hand. Don't go to change view, because then it'll be hard to assist you in live, because in this change view you can say that you only want to see interventions that are in a canceled status. So all of your active interventions won't show up on your work list, and then you're really in a pickle. And you're like, why can't I see anything? They're on my care plan, they're active, they're not on my work list. That could be why, but we have to check about 4 or 5 places before we can help you with that. So change view is a don't go there. It'll be an advanced function down the road, like in the fall. Go ahead and turn the page. Remember how I had that little screen that popped up that said I had duplicate interventions? Well, here's a new pop-up, and this is the review that Kathy was asking about. So at the beginning of every shift, we need to come, because we default into the work list when we open the chart, we need to come to plan of care, and there's a footer button for reviewed. When you click on reviewed, this is the screenshot of the message that you get, and it simply says you're agreeing that you have performed a thorough review of the patient's entire plan of care, okay? And it'll even list if there's been a previous review on there or not. Now, there's no definition of thorough review, so you went in, you looked at the care plan, you thought, yep, this seems to apply. We don't have like abruptio placenta on a male patient, so I think I'm going to agree with this. And hit yes. You've just completed it. There's a time and date stamp with your name on it that says you reviewed your care plan at the start of your shift. Okay? Just open up the plan of care and hit reviewed. Does anybody remember what this rank footer button was for?
So you can change
Just
the
to read
range
your
for
problems.
Ranking your problems, yep. CPR or chest pain, you know, what do you do? The utility footer button is the last footer button. And if you turn in your binders, you have a page like this. And I have highlight in there the duplicates, move miscellaneous, and the status, because those are really the 3 main functions that we would use in this utility footer button. So go ahead and just follow along with me up here. When I click on problems, I have these next row of buttons, suggested, status, rank, and move miscellaneous. When I click on outcomes, my buttons are a little different. I have targets, I have frequencies, status, and modifiers. I have interventions, different buttons. And then I bet you can guess what review does. Exactly the same thing as the other button did, just another place you can do it from. So when I'm on problems, I can find anything with a status of all, or I can just find only the inactive ones, and I can change them all at once as one big mass edit to active. And then if I save it, apply and save footer button, I've just changed them all. And I have a few duplicate interventions. We're gonna ignore that for right now. In my outcomes, and I can also rank, I can go through and I can rank everything that I have as listed as a problem or nursing diagnosis for this patient and which one's the most important, okay? Mood miscellaneous. I added these 2 problems as miscellaneous problems. I want to include them in which plan? Anemia, angina, or API? API. And I apply and save it. They're no longer going to be hanging out there as miscellaneous, okay? It's kind of how, this is like your cleanup utility bucket. It's kind of like the big yellow cart with the mop and the broom for care plans, okay? That's the utility button. When you click on interventions, this is the main place that you're going to use utility for, because in interventions, this is where I went and I had that duplicates, and I can see that I've resolved these duplicates already. These are still unresolved, and I can go through, and what do I click on in order to resolve a duplicate? I click on a status, and I can change it from active to cancel, and I can make a decision on which one I want to leave it active on. So I see that this one was ranked as a 10, so I'm probably going to keep the rank of 6 instead of the 10. There's just a few ways that you can kind of clean up those duplicates. If I have duplicate interventions on my plan of care, I have duplicate interventions on my work list. Teach reportable signs and symptoms is on there twice. So if that's bothering you and you want to get rid of it, that's something that we can change. And you can change it one by one at the plan of care. You can come to this utilities screen by clicking on plan of care, click on the footer button utility, see what you have for unresolved duplicates in interventions, and fix it from there. Okay? There's a few ways to go about doing it. The status of an intervention, you can change anything with a discharge status, because at discharge, everything will go to a discharge status. But, I still needed to document that last set of vitals. Change anything that's discharged back to active, document your vital signs, change it back to discharge. You can do that here. Move miscellaneous works just like the last one we did. You have survived Care Plans Meditech 101. We're going to walk you through your binder real quick. In the utility screen, here's a screenshot of what the available functions are in utility for outcomes. The reason I didn't include a screenshot of problems is because it was listed on the first help page, okay? The next button is outcomes. It lists those functions. It's there for your reference in case you don't remember where to click in Meditech to get there, but you know that you learned it somewhere and you can be like, how do I get to this screen? How do I get back here? It's there for you. Interventions, duplicates and unresolved are highlighted on there because that might be one that we want to use frequently. Interventions and status is highlighted on a screenshot. That might be one we want to use frequently. And the last one is move miscellaneous, one we might want to use frequently. This review is the same as the reviewed footer button in the main page of the care plan. Just one more place you can do it. Why not? That's the last page of your binder. Do you guys have any questions about this care planning stuff? How it applies to you in your daily life? Okay, it makes you cringe a little bit. So what we've reviewed today is how to log in, and you have 2 desktops. You have the test ring and the live ring, right? Always in the test when we're practicing. You log in, you open up, your default list is my list. It's blank. We talked about how to make assignments and how to get people onto your list with just the edit my list routine that you don't even have to go into assignments. And then we went on and we talked about all the functions of the columns of the status board. The buttons on the right are called body buttons. The buttons on the bottom are called footer buttons. They're a little different on every screen. But the buttons in the bottom right-hand corner, external links, are the same in every screen. And you're going to love the help button because you get stuck somewhere, you click help, and you can click in that screen to find more help for what you need, okay? Then we went into opening a patient chart. How many charts can you have open at a time? 2. And then we went into, once you open the chart and you don't have anything on your work list, how you can get stuff onto your work list to document. What's the one thing that anybody can put on a work list? A standard of care. Yep. fits within our practices. Other than that, we went through what it means to create a care plan for a nurse and what it means to work through a care plan as a team. So that wraps up our discussion. We have a little bit of an introduction to the work list on how to document from that and how things show clocks and what the different colors mean on there and all of that stuff. And we're gonna pick up there on our next class next week, okay? You guys were great today. Thank you so much.